for accepting this invitation. For me, it's quite amazing. So you can share your knowledge with us.
No, thank you.
You've been working a lot since I entered the endoscopic ear surgery world. You've been there as one of the main chairs.
Yeah, it's a long time. Now I'm quite old, so
No, you're not. And well, we're all being grateful for all your work you've always been doing and everything.
thank you very much. So if you want, I can try to share the screen.
Perfect.
And to start the lectures, let me check. Okay, are you able to see the screen?
Yes, I am, and I am recording. So if it's okay with you, I will record the session and then upload it to social media. That's the idea.
No problem. So these lectures regarding the transcanal approach to the internal auditory canal, it's endoscope versus microscope. So it means that it's not just a question of the endoscopic approach, but it's just a question of anatomy. Everything is a question of anatomy, is not a question of the tool. But anyway, I think that it's really important to explain the two different kind of approaches because we codify the transcanal transpromontory approach just because we started to use the endoscope several years ago, and we started to understand the anatomy from the external auditory canal to the internal auditory canal, and after we started to remove some acoustic tumor through the canal. But anyway, recently we developed also an expanded transpromontory approach requiring microscopic surgery. So it's not a question of the tool, but especially of the anatomy. We know that in lateral skull base we have several approaches in order to reach the internal auditory canal, and in my mind, it's really important for a surgeon, especially for a skull base surgeon, to learn and to perform all these kind of approaches, because you can learn the anatomy from different point of view. So we can have a middle cranial fossa, retrosigmoid approach, infratemporal approaches, transtemporal approaches, and at the end we can use also the transpromontory and transcanal approach in this flowchart in order to reach the internal auditory canal. Today we are focused our attention just in the transpromontory transcanal approach, so we can start to understand how to reach the internal auditory canal from the external auditory canal. Already, this is a view from middle cranial fossa of the internal auditory canal, and you can see here there is the fundus of the internal auditory canal, and this is the porus. Already, it's really important when we codify the transpromontory approach to see and to understand the anatomy on the CT scan of the internal auditory canal, because when you are reaching from the external auditory canal the porus of the internal auditory canal, you need to know the distance between the external auditory canal to the porus of the internal auditory canal. And we can have a different kind of conformation of the internal auditory canal. We can have a shorter one, or a really long internal auditory canal, where the distance from the fundus to the porus is quite long. And in that cases, when you have a narrow and long internal auditory canal, the transpromontory approach is quite difficult. It's more difficult with respect to a shorter internal auditory canal. Another important detail is the jugular bulb condition. If you have a really high jugular bulb, the space in order to reach the fundus of the internal auditory canal and the porus is quite narrow. So it's better to perform other kind of approaches. The transpromontory approach is meant to reach from the external auditory canal, removing the eardrum, removing the ossiculary chain, and entering into the promontory region in order to reach the fundus of the internal auditory canal and dissecting the internal auditory canal until the porus. So this is the aim of the approach, and why we thought about this approach, because it's like the anterior skull base. You know that the evolutions of the anterior skull base is through the nose and through the paranasal sinus, is to use a nose corridor in order to reach the target. And the target is the anterior skull base. For example, is like a meningioma. You can have a small lesion, intradural lesion like a meningioma. You can have also some tumor located in the paranasal sinus entering into the anterior fossa, and you can manage through the nose. Which kind of advantages? The advantages is less manipulations of the brain, working on the target, removing the disease. And this is the same in the transpromontory approach. We have to working just on the internal auditory canal, and you need to manage the dura of the middle fossa, the jugular bulb, the dura posterior fossa, the brainstem, the cerebellum, is just to reach the target that is located in the internal auditory canal in order to minimize the approach. Which kind of disease we can treat through the canal, and especially performing a transpromontory approach. The first disease that we treated was a infralabyrinthine tumor. The infralabyrinthine tumor is a tumor located inside the labyrinthine, inside the cochlea, reaching just the fundus. And you know that is a really small tumor, but in the majority of the cases, you can have a patient with terrible vertigo and a really important symptom requiring surgery. And so one of the targets in this case is just the fundus of the internal auditory canal. And you can see the external auditory canal is here, and the cochlea is here, and this is the fundus. And this way is our target working in this area. But you can have also some other acoustic tumor like this growing during the time, located just in the internal auditory canal from the fundus to the porus, invading also the cochlea. And in that cases, you can have also vertigo and problem with the patients, or tumor like this, you can see with a tumor growing from the internal auditory canal, spreading just a little bit in the cerebellopontine angle. And in that case, it's really important to have a wide approach. And so the transpromontory approach, and we codify the expanded transpromontory approach just in order to manage inside the cerebellopontine angle the tumor, because you know that it is not possible to perform this kind of tumor with a narrow canal. So you have to enlarge the approach, and so we codify the expanded transpromontory approach requiring, of course, the microscope. We can start so with this kind of divisions regarding the transcanal approaches. We can have a transpromontorial approach, endoscopic, is really important when we want to manage tumor located from the fundus to the porus, and the limit is the porus. After the porus, it's not possible to perform just transcanal transpromontory approach, or we can do an enlarged, expanded transcanal transpromontory approach using the microscope, and the target is tumor located from the fundus to the entry zone of the facial nerve, because in this approach you can reach the dura of the posterior fossa, you can cut the dura of the posterior fossa, and you are able to work really close to the entry zone of the facial nerve, but requiring some kind of tumor, especially acoustic tumor, with growing in the straight line with respect to the internal auditory canal, and with a small dimension, and not so huge inside the cerebellopontine angle. The surgical step, we can start with the endoscopic approach, but the microscopic approach is quite similar. We can cut the external auditory canal in the circumferential way, and after we have to detach the skin of the external auditory canal until the eardrum, and we have to dissect the eardrum and block together with the skin, removing from the external auditory canal. So we are removing the skin and the eardrum. And you can see in this drawing, we can see the line of incision and the bone after the external auditory canal skin removal. After this, with the endoscope, we are in this condition. You can see after eardrum removal, we can see the malleus here, incus and stapes, the facial nerve run over there, and the coda. And in order to have the possibility to work inside the medial wall of the tympanic cavity, it's really important to remove the bone around the external auditory canal. So you need a drill, and you need to drill all the wall of the external auditory canal bone in order to get the space to work inside the cavity. So with the diamond burr, that is the most important aspect, we can start to remove all the bone, but we need to know the limits of the drilling. You know, anteriorly, we can have the temporal mandibular joint that in the majority of the cases is a good thing to see and where it's located and to dissect. After, in the deep part of the dissection, you have to remove the bone in the anterior annulus bone, and in order to see the area of the protympanic space where is located the carotid artery, we have to remove the bone in the hypotympanic cell in order to see the jugular valve, and posteriorly, we have to remove the bone until where we know where is located the third portions of the facial nerve. And also in the attic, we have to remove the scutum in order to uncover the incudo-malleolar joint. So we can see now again. Oh, sorry. Where is? After the enlargement of the external auditory canal, you are able to see all the protympanic space, hypotympanic space, retrotympanic space, and epitympanic space with the incudo-malleolar joint. So it's really important to have this view. When you have this view, it means that you are able to manage and to move your instrument in an appropriate way inside the tympanic cavity. After this, we have to remove the ossiculary chain. So we have to detach the incus and the malleus. And after this maneuver, it's possible to see in a clearly way the facial nerve, the tympanic segment of the facial nerve, run just superiorly with respect to the stapes here. Anteriorly, we can see here the cochlea-reform process and the cog, and between the cochlea-reform process and the cog, there is the space where is located the geniculate ganglion. Immediately after the ossiculary chain removal, we are able also to see the lateral semicircular canal and the antrum. But our target is the fundus of the internal auditory canal. Where is located the fundus of the internal auditory canal in this drawing? You can see this is the stapes and the articulation between the stapes and the oval window. And we know that we are removing the stapes, we are entering into the vestibule. The fundus of the internal auditory canal is located just anteriorly and inferiorly with respect to the vestibule. So in this area, of course, in the deepest part of this area. So we start to remove the stapes, entering into the vestibule, and this is the medial wall of the vestibule. And inside the medial wall of the vestibule, we can see and we can recognize this area, that is the spherical recess where is located the inferior vestibular nerve. This is the attachment of the inferior vestibular nerve to the vestibule. So it's a landmark in order to understand where is located the fundus of the internal auditory canal. Again, we can see in this slide, and we can recognize the anatomy. Tympanic segment of the facial nerve, the geniculate ganglion, the GSPN. This is the cochlea-reform process, the promontory region where is located the cochlea, And where is located the fundus? Just to put a line between the geniculate ganglion and the spherical recess, and you can have the projections of the labyrinthine portions of the facial nerve. And this is the area of the fundus of the internal auditory canal. The orientation of the internal auditory canal is like this, is a quite oblique orientation from here to here posteriorly, from superficial aspect to the deepest part of the internal auditory canal. In order to enter into the fundus of the internal auditory canal, we can start the transpromontory approach. To start the transpromontory approach, we have to remove the bone on the promontory region, uncovering the cochlea, the basal turn of the cochlea with the scala tympani and the scala vestibuli, and the middle turn of the cochlea and the apical turn of the cochlea until we can see the helicotrema. Before to do this, you must know where is located the carotid artery, just to detect where is located, and the jugular bulb, because this triangle is your space during the dissection. So now we have the vestibule here, spherical recess, the basal turn of the cochlea, middle and apical turn. And from geniculate ganglion, the labyrinthine portion of the facial nerve turns just immediately over the cochlea, entering into the fundus of the internal auditory canal. Now we have all the anatomical landmark in order to understand where is located the fundus of the internal auditory canal, in order to enter into the fundus of the internal auditory canal. Where we have to drill? We have to drill in this area. You can see this triangle of bone between the cochlea and the vestibule, this bone. This bone, we call it, this bone, the cochlear vestibular bone, is the bone in the middle between the vestibule and the cochlea. And if you remove this bone, you are entering into the fundus of the internal auditory canal, and you can see the nerves, the vestibular nerves, the cochlear nerves, and just a little bit deep, the facial nerve. So this is our target. So we can start to see in detail the anatomy between the cochlea and the vestibule, and you can see here medial wall of the vestibule with the spherical recess, basal turn of the cochlea, middle and apical turn, and this is the cochlear vestibular bone. We have to remove this bone, and we are able to enter into the fundus of the internal auditory canal. You can see here this triangle we have to remove. And after, here we are, this is the fundus of the internal auditory canal with the projections of the nerves. And the first nerve that you meet is the cochlear nerve and the inferior vestibular nerve. And just a little bit more deep, there is the facial nerve in the middle between the cochlear nerve and inferior vestibular nerve. And the superior vestibular nerve is just a little bit deeper and superior with respect to the inferior vestibular nerve. From this point of view, is completely different with respect to the translabyrinthine approach, is completely different with respect to the middle cranial fossa and the retrosigmoid approach. So this is the real projections of the cochlear vestibular bone after cochlear vestibular bone removal. When you are removing the cochlear vestibular bone, you are reaching the fundus of the internal auditory canal. So you can start to remove the bone around the fundus of the internal auditory canal, following the dura of the internal auditory canal, removing the bone between the carotid artery and the anterior aspect of the internal auditory canal dura, and between the third portions of the facial nerve and the posterior aspect of the internal auditory canal dura, until the porus. So you have to drill until all the internal auditory canal is skeletonized until the porus. And this is the porus, this is the fundus. When you are able to reach the porus, you can cut the dura of the internal auditory canal, and you can see the tumor, and you can start to remove the tumor. Look in this drawing. where it's possible to see the acoustic neuroma, and this is the door of the internal auditory canal. It's very important to remove the bone around the internal auditory canal in order to skeletonize, like in the translabyrinthine approach, but this is through the canal. Of course, when you are reaching the tumor, after you are able to dissect the tumor from the internal auditory canal, of course, and preserving the facial nerve. And this is the defect in the promontory region from the fundus to the porus after tumor removal. And at the end, you are able to remove the tumor from the external auditory canal, but you need to close the defect. The first thing to do is to close the Eustachian tube, and you can use a muscle, bony wax, or you can use also this pedicle flap arising from the muscle of the tensor tendon muscle. You can see, you just remove the cochleariform process and detach the muscle from the channel and pushing inside the Eustachian tube. So this is really important, and pushing inside the Eustachian tube in order to close the Eustachian tube. The second situation is to close the defect from the promontory region to the cerebellopontinegol. And in order to do this, you have to put a fat pad and pushing the fat pad and inside the defect in order to close the connection between the tympanic cavity and the cerebellopontinegol. And after, you have to fill the cavity with the fat, and you can see in this drawing all the fat is inside the cavity and until the cerebellopontinegol like this. And after, you can reverse the skin, detaching from the cartilage in order to close the external auditory canal. And this is the most safe way to do this approach. When is indicated? Is indicated just in some cases. In sporadic acoustic tumor cause number 1, this is the total endoscopic approach, or intralabyrinthine tumor. Intralabyrinthine tumor, where the tumor is inside the cochlea, inside the vestibule, or both, or invading the fundus of the internal auditory canal, and in that cases, you can use the transcanal endoscopic approach. This is, for example, a case of a transcanal endoscopic approach for a young man affected by acoustic tumor inside intralabyrinthine tumor. You can see the removal of the skin and the eardrum, the drill in order to uncover the middle wall of the tympanic cavity. And you can see here after ossiculary chain removal, the view of the round window, the stapes, and the facial nerve. This is the fustis, this is the funiculum and the subiculum, etc., etc. We can start to open the cochlea, of course, and cut the tendon of the stapes and removing the stapes, entering into the vestibule. And this is the vestibule, this is the basal turn of the cochlea, and this is the middle turn and apical turn of the cochlea. And you can see now the situation: vestibule, facial nerve, basal turn of the cochlea with the tumor, middle turn and apical turn of the cochlea. And this is the cochlear vestibular bone, the bone between the cochlea and the vestibule, and where is located the fundus of the internal auditory canal. So we can start to remove the cochlear vestibular bone, entering into the fundus. And you can see the tumor now. This is the tumor, this is the tumor, this is the tumor. This is the tumor located inside the scala tympani, and we are removing. And instead, the other part of the tumor is inside the fundus, and this is the fundus. Of course, when you're working on the fundus, you have the leakage. This is the last piece of the tumor, and look now the nerves. You can see again, this is the cochlear nerves entering in the modulus and the middle turn, apical turn of the cochlea and basal turn. This is the inferior vestibular nerve attaching to the spherical recess and the superior vestibular nerve attaching to the elliptical recess, and in the middle there is the facial nerve in the deepest position. You can see now better after tumor removal, and this is the defect of the fundus of the internal auditory canal. The tumor is gone. It's really quick operation, and after you can start with the closure. The closure is really important to do the closure of the Eustachian tube. We are doing now a flap, a pedicle flap with a tensor tendon muscle pushing inside the Eustachian tube. And for the defect of the promontory region, we are using a fat pad pushing inside the defect in order to stop the leakage, in order to close the connection between the tympanic cavity and the cerebellopontine angle. And after, we can start to reverse the skin, removing the skin from the cartilage. You can see the dissection from the cartilage, and in order to have a reversion of the skin and the closure of the Eustachian tube. This is another case of acoustic neuroma growing during the time. Another important aspect of this approach, of course, all the patient should have a hearing loss, of course, neurosensory hearing loss, and this is really important. So now we can see the drilling time and the removal of the incus here, removal of the malleus. Again, after ossicular chain removal, we are able to see the facial nerve, the stapes, and we can start to see the removal of the stapes with the vestibule. Again, we have to remove the promontory region, uncovering the cochlea, and this is the basal turn of the cochlea, middle and apical turn, and the vestibule. Again, this is the door of the internal auditory canal. Vestibule is here, basal turn is here, middle and apical turn, and this is the cochlear vestibular bone. Removing this bone, we can go directly to the fundus of the internal auditory canal, and this is the tumor with the fundus. So we can start to dissect the internal auditory canal from the fundus to the polus. In this case, in order to see the tumor, this is all the tumor inside the tympanic cavity. And now it's really important to use some instrument. Sometimes you can use also two hands, because like in the anterior skull base, your assistant can hold the endoscope and you can use two instruments. You can see now this is the sac of the tumor, and just moving in a really soft way, you can see to start to see the leakage. This means that the posterior aspect of the tumor is gone, and after you are able to see the facial nerve, and you can start to dissect the tumor from the facial nerve. This is the last part, and the tumor removal. After this, and this is the facial nerve after the finish point. Microscopic approach, and when we started this approach, we started just endoscopically, but we had some criticism from the otology community regarding the possibility to use the endoscope if the tumor go inside the cerebellopontine angle. That is quite possible also, but in my experience, I didn't have any problem with the ICA or something like this, honestly. But anyway, just because we thought about, we decided to use the microscope in order to enlarge more this approach, in order to understand if it was possible to work inside the cerebellopontine angle through the transpromontorial approach. And so this was the transpromontorial approach that is indicated just for infralabyrinthine tumor, of course, and sporadic acoustic tumor, cause also number 2, and in some cases of cause number 3, when the tumor is growing in the straight line with the internal auditory canal. These are the actually indication in this approach. You need to do a retroauricular incision, really small retroauricular incision, and enlarging the canal, you can reach this anatomy. You can see that this is the same anatomy. The difference between the microscopic and endoscopic approach is that you have to dissect in a clearly way the carotid, the jugular bulb, and the third portions of the facial nerve in order to enlarge your surgical window. You can see tympanic segment of the facial nerve, third portions of the facial nerve, jugular bulb, and vertical portions of the carotid artery. You have to see the structures, but not dissect, just to see. And after, you can have all the detail. You can see now that we are reaching the cochlea, and look, we have the same anatomy of the endoscopic approach. Geniculate ganglion is here, tympanic segment, third portions of the facial nerve, basal turn, middle and apical turn, and vestibule. And this is the cochlear vestibular bone. This is the vertical portions of the carotid and the jugular bulb. So we can start to remove this bone in order to see the internal auditory canal. And you can see this is the internal auditory canal from the fundus to the porus. We have to reach the porus from here, and we have to enlarge more and more our approach. You can see the cutting the dura of the posterior fossa. Here we are, and this is the entry zone of the facial nerve. So we are able, through the promontory region, to work in the cerebellopontinangula, and this is the defect. Look at the facial nerve, geniculate ganglion, labyrinthine portions of the facial nerve, and the facial nerve inside the cerebellopontinangula, and this is the entry zone. This is the second genu of the facial nerve, third portions of the facial nerve, jugular bulb, carotid artery. And this is all the window of this approach. Advantages and disadvantages regarding all the approaches for the internal auditory canal. And this is an article, and we put also the endoscopic approach and the expanded endoscopic approach. You can see this is the transpromontory approach endoscopically, and this is the microscopic expanded transcanal approach. The advantages, of course, are excellent possibility to work on the internal auditory canal without manipulations of the brainstem, cerebellum, and the middle and the posterior fossa dura. And so it's a minimally invasive access with respect to the other kind of approaches, low morbidity, and the excellent control of the facial nerve. And of course, the disadvantages is that you have to perform this with the demolitions of the cochlea. And we know that nowadays some behavior is to try to restore the hearing function performing a cochlear implant, especially in the small acoustic neuroma. So because of that, we started to think about a transpromontory, infrapromontory approach with the possibility to use also the cochlear implant through this route. So at the end, you can see now this drawing representing the infracochlear approach. It's meant to perform the same approach, but you have to remove the bone of the tegmen of the round window. After this, you have to following the basal turn until the most anterior portions of the basal turn in order to uncover here the cochlear vestibular bone, and you can start to dissect the fundus of the internal auditory canal in this area until the porus in order to maintain the most anterior portions of the basal turn, the middle and apical turn of the cochlea, in order to have this, in order to remove the tumor and performing a cochlear implant in the same stage. You can see here we are able to preserve the basal turn of the cochlea in the most anterior portion, middle and apical turn, the vestibule, fundus of the internal auditory canal, and this is the porus. For example, this is a case of a lady, a young lady, who was a singer, and she lost the hearing function in this side, and this tumor was growing during the follow-up. And so we decided to perform surgery because of the growing tumor and the dizziness of the patients, but the patient asked the possibility to perform a cochlear implant. Of course, and this is the approach, and is the transpromontorial enlarged approach through the canal, and you can see here. And this is the drilling time. Again, we are able to see now the removal of the incus is here. The facial nerve is over there. We have to remove the malleus. And the stapes is here, facial nerve is here. And now we can start to see. This is the jugular valve, the carotid is here, the vestibule is here. We have to remove the promontory region, and following the basal turn of the cochlea until the most anterior portions of the cochlea, the basal turn. The third portions of the facial nerve is here. And look, this is the basal turn of the cochlea, jugular and carotid is here. And so we can start to dissect the fundus of the internal auditory canal from here. You can see again, this is the internal auditory canal, and this is the basal turn of the cochlea. Again, and you can see all the internal auditory canal, and we are reaching the dura of the posterior fossa. And now we have the internal auditory canal, all the dura of the posterior fossa, the carotid is here, the jugular valve is here, and we can cut the dura of the posterior fossa in order to have an access to the entry zone where is located the tumor. And this is the tumor removal. But we are preserving the basal turn of the cochlea, middle and apical turn. You can see here that there is the tumor removal. Again, from the entry zone. And after tumor removal, this is the cavity. You can see this is the acoustic facial bundle, the entry zone. And now we can use the cochlear implant in order to restoring the hearing. Of course, in order to do this, you have to preserve the cochlear nerve and the facial nerve, of course. And in this case, we were able to preserve the cochlear nerve and the vascularization of the cochlear nerve. So this is something, a new frontier. Nowadays, just few patients underwent this kind of surgery, but the results are really promising, especially and when you are treating a small tumor. This is the results of the cochlear implant with the infrapromontorial approach for the acoustic neuron. So, in conclusion, the transpromontorial approach and the surgery of the YAC, the transcanal surgery of the YAC, now is possible using endoscope and microscope. There are some disadvantages and advantages. Of course, it's not possible to use just the root. It's really important to perform all kinds of surgery for lateral skull base, the translabyrinthine approach and middle cranial fossa, and retrosigmoid approach. But nowadays, we can use also the transpromontory approach. It's really important to use with all kinds of approaches in the management of the acoustic tumor and in the management of the lateral skull base disease. So thank you very much for your attention.
Thank you, Professor Marchioni. Couple of questions. Normally, have you tried, as you said before in the beginning of the presentation, that the lateral corridor is like the anterior corridor for the anterior skull base surgery. Have you tried with the enlarged approach, with the microscopic enlarged approach, then to use a forehand technique with the endoscope and two surgeons?
Yes, when I'm doing endoscopic transpromotor approach, sometimes if you have some adhesion, for example, from the disease to the facial nerve requiring a two-hand dissection, one of your assistant can hold the endoscope and you can dissect with two hands. So this is possible. It's like the anterior skull base that in the majority of the cases, there is two surgeons, one hold the endoscope and the other one performing the dissection. And this is the same with the transcanal endoscopic approach. Of course, with a large approach, you needn't because you are able to use two hands.
So you have no space problem while working with the endoscope and two instruments. You have this.
The secret is to remove as much as possible the bone in the external auditory canal, because if you don't perform a good bony work on the external auditory canal, you are not able to move your instruments with two hands, but also with one hand sometimes, because one of the secrets of the transpromontory approach is the first step of the drilling of the external auditory canal. You have to reach the temporal mandibular joint, and to dissect all the temporal mandibular joint, you have to remove all the bones superiorly in the scutum removal, etc. In the hypotympanum to see the jugular bulb, and posteriorly to see the third portions of the facial nerve. In this way, you can get the space to work with the three hands.
Perfect. And we've seen a lot of well, the two cases that it's well as the same as I think that in translab approach, you more or less likely have to encounter the tumor in the lateral aspect of the IAC, right? So the first thing you encounter while you're drilling is the tumor, normally.
Yes, is a tumor.
Okay.
The position of the facial nerve is deep with respect to tumor in this approach. For example, in the middle fossa, the first thing that you meet is the facial nerve. And in the translab, you can understand better because the facial nerve is under the superior vestibular nerve. So we can follow in the facial nerve. In this approach, the facial nerve is the most deepest nerves.
So normally you can just pull the tumor gently and it will come with you.
Yes, dissecting the capsules of the tumor, of course, in a soft way, respecting the most deepest part of the part of the internal auditory canal. It's quite constant, the positions of the facial nerve in this approach. Is the most deepest nerve and is always between the cochlear nerves and the superior vestibular nerve. But of course, when there is the tumor, the first thing that you meet is the tumor.
Perfect. And more or less, how in trained hands, how long does the surgery takes?
Depends on the tumor. For example, infralabyrinthine tumor, it's 1 hour and a half. It's really fast. If you have a tumor located from the fundus to the entry zone of the facial nerve, is different. You require quite of less, just a little bit less with respect to translabyrinthine approach, but of course you need time, because the problem is the working on the tumor in the cerebellopontine angle, requiring always time. And so depending on the position of the tumor, if you have just a small tumor in the fundus, it's really fast. If you have a tumor from the fundus to the entry zone, it's faster with respect to the translab, but we are almost
more or less.
Yes.
Perfect. And regarding, do you have any data regarding the CSF leak?
Yes, I have the data. The complication, we in our series, we have no bleeding in all cases. So I hope that also will be in the future. I don't know, but so this is really important, because at the beginning we were afraid regarding the bleeding or something like this. And regarding the leakage, we have 1% of the cases where the leakage, were just requiring a bandage, and really rare you need to perform again the surgery in order to pack the cavity. And the leakage was not from the nose, but from the scar of the tissue. So also in this way, it's really important to pack in appropriate way the Eustachian tube. And if you have some leakage in the skin, just to perform a suture and the bandage and the compressive way, and during the time you can resolve the problem. Facial nerve, and we have some data with regarding the facial nerve, and we have this was the last work that we did in a publication. We have about 7% of possible facial palsy with transient facial palsy. So it's instead, in 2% of the cases, we had a permanent problem with the facial palsy. And just to show which kind of surgery we had this kind of complication, especially at the beginning when we pushed the endoscope through the cerebello-pontinangolo. Sometimes we didn't understand if it was the hitting of the nerve because the tip of the endoscope. But anyway, in that cases, the patient had just a little bit more problem, but the percentage is really low, honestly. And comparing with the translab approach, there is no difference, honestly.
So I understand with the presentation that you actually have moved for treating intracanalicular acoustic neuromas from the translab approach to the transpromontorial approach in every case, or you still
in the intracanalicular, depend on the conformations of the internal auditory canal. It's really important, in my opinion, to check the CT scan. Sometimes when I have a small internal auditory canal, really narrow and really long, sometimes I prefer to perform translabyrinthine approach, because the surgical field with the transpromontory approach is really deep. You understand?
Yeah.
And instead, but just in some cases. When I have instead a normal internal auditory canal and I have a tumor located in the vestibule, in the cochlea, on the fundus of the internal auditory canal, inside the internal auditory canal, the transpromontory is really fast, and so is the first choice.
Perfect.
The problem is when you have a tumor, cause number 2, located in the internal auditory canal and also invading just a little bit the angle. In the majority of the cases, you can decide if you want to do a transpromontory enlarged approach or translabyrinthine approach. In the majority of the cases, honestly, I'm performing translabyrinthine approach, unless there is some tumor that is growing in the really straight line with the internal auditory canal, with the short canal, and so in that cases, I can do transpromontorial just because it's faster, but it's just a detail.
Okay, I think I'm done with the questions. Maybe I will have more in a couple of days, but now I'm fine. Thank you, Daniel,
You're welcome.
for your time, and we'll see you definitely in Kyoto.
Yes.
And hope to see you everyone there.
Thank you. So
Thank
please
you.
take care.
Thank you very much.
I stop the sharing the screen.
Perfect.
Okay.
That's okay.
Thank you very much for your kind invitation.
No, thank you. I will maybe I will contact you again for another session if it's fine with you in the future.
Okay.
Thanks, Professor.
Bye. Thank you.
Bye.
Bye.
Thank you.